Well, welcome everyone. We are so glad you can join us. Welcome to the October session of the Virtual Learning Collaborative, which is today we're going to discuss the health system and lab assessments. And this is made possible in partnership with the CDC's Division of Viral Hepatitis. My name is Isabel Lechuga. I use she, aya pronouns, and I'm part of the hepatitis team at NASTAD. So I'm very excited that today joining us are Dr. Liisa Randall from the Massachusetts Department of, I just wrote DPH, Department of Public Health. I hope that's correct. Director, Healthcare Planning, and member of HepTAC's Advisory Committee, and Danica Kuncio, who is the Viral Hepatitis Program Manager with the Philadelphia Department of Health. So the format for today's session is as follows. We're going to begin with a presentation from Dr. Randall on the soon-to-be released resource, Viral Hepatitis Testing, Strategies for Assessing Laboratories and Their Approach in Massachusetts, followed by a poll led by Danica Kuncio on the elements to include in the health system assessment, and ending with a discussion and Q&A with the audience, facilitated by yours truly. Feel free to use the chat, like I mentioned, to introduce yourself and jurisdiction and for your questions. So with that, I will turn it over to Dr. Randall.
Thanks, Isabel. The first thing I'm going to attempt to do is to successfully share my screen, which is going to be a trick.
Ooh, yes.
Are we doing good?
Yes. Beautiful.
Have we had success?
We did it.
Awesome.
I knew we would.
This is a first. This is definitely a first. All right, good afternoon. I am really pleased to be able to join you this afternoon to give you an introduction to a resource created by NASTAD, the Viral Hepatitis Testing, Strategies for Assessing Laboratories. NASTAD created this toolkit to assist health departments to assess their viral hepatitis testing capacities and practices in laboratories in your jurisdictions. The content of the toolkit is directly responsive to the issues and questions that have been brought forward by health departments undertaking assessment of laboratories. And the toolkit presents best practices and includes practical examples. In developing this toolkit, we wanted to provide a step-by-step approach to conducting assessment, including why conducting assessment of laboratory viral hepatitis testing practices is useful beyond meeting federal funding requirements, what types of information health departments might try to collect, how might health departments identify and connect with laboratories, the methods and approaches that might be used by health departments for assessment, as well as resources and tips. Broadly speaking, learning more about the current practices and capacities of laboratories relative to viral hepatitis testing is really foundational to helping us achieve our public health goals and objectives. It's useful for us to know what tests laboratories perform, in what order, and under what circumstances. It's useful for us to know what potential capacities laboratories may have in terms of what they're able to do in-house, what they have to do through referral, the throughput volume of various tests, and the testing platforms used. Knowing more about what laboratories are up to and what opportunities there might be to promote changes can help us to strengthen our public health surveillance, advance expansion of screening and diagnostic testing, and promote and support treatment engagement and completion. What we can learn from assessment of laboratories should help guide outreach, education, training, and capacity building that health departments, that laboratories themselves, that healthcare facilities, and other stakeholders may undertake to strengthen our collective ability to identify and successfully treat viral hepatitis. There are a number of topics or issues that health departments could include in an assessment. Health departments, in developing your assessments, really need to determine which areas are best aligned with your overall objectives. One area is laboratory capacity, and this includes what tests are performed by the laboratory in-house, on what platforms those tests are performed, and at what levels of throughput. This information can help inform an understanding of where there might be room for implementation or expansion. For example, depending upon testing platforms and workflows used in a lab, they may be able to handle an increased volume of testing. There may be underutilized capacity in that laboratory based on the platforms that they are using currently for viral hepatitis or related infections. Most contemporary test platforms test for multiple infections. This is known as multiplex testing. If a lab is testing for hepatitis C, for example, they may be able to add on hepatitis B testing in a relatively straightforward fashion. Similarly, if a laboratory is testing for gonorrhea or chlamydia, they probably have a platform that can perform hepatitis C RNA testing. APHL has a really handy tool, and at some point we can get you the link to it that summarizes various testing platforms that are currently in use for HIV, hepatitis, sexually transmitted infections, and it can show you which platforms test for which infection. So it'll give you an idea of what multiplex options may be available. A second area of inquiry is laboratory workflows and standard practices. And this include what tests can be ordered and how those orders occur, and what tests might get referred to other laboratories and under what circumstances. All laboratories don't offer all tests. And even if a laboratory offers a test or a sequence of tests, they may not actually perform any or all of those tests in-house. Even if a laboratory offers a test or sequence of tests, it may only do so in particular circumstances, such as in the case of healthcare exposures. It's very common for clinical labs to refer high complexity tests, which molecular testing tests are, to another lab, either a core hospital laboratory or a commercial laboratory or some other reference laboratory. Learning more about the workflows that are in place with a laboratory can help you to identify where there might be gaps in the testing process that are barriers to implementing testing, or which delay diagnosis, or which make it difficult to classify a case. You might also consider assessing challenges and facilitators that would be associated with changing current laboratory practices or workflows. In determining what tests they'll offer, laboratories, what tests they'll offer, they'll perform, and under what circumstances and at what level, laboratories are going to consider a range of administrative, operational, and budget factors, just like any other administrative process of decision-making, like we would do in the context of our viral hepatitis programs. We need to determine what's feasible and what we can get done within the resources that we have. Getting an understanding of the challenges and opportunities labs have or expect that they might have in making the kinds of changes like we would like them to make, such as implementing reflex testing, is important to actually stimulating these changes. Finally, you might also consider assessing data collected by laboratories. Your assessment might be an opportunity to learn whether individual labs are reporting consistently or timely. And lab data, particularly from a public health perspective, is often woefully incomplete. Whether and how it might be possible to improve completeness of reporting, such as by leveraging the EHRs that are contributing to laboratory orders, might be part of your assessment. So how do we go about identifying and connecting with laboratories? There are a few possibilities that might be able to help you identify the laboratories that you want to include in your assessment and connect with individuals in the laboratories to respond to your assessment activities. State and local public health laboratories, irrespective of whether they're actually performing any hepatitis testing, are a great collaborator and a great partner in assessing clinical laboratories. Public health laboratories maintain active communication and coordination with commercial and clinical laboratories in your jurisdiction. Most public health labs conduct outreach and education with clinical and commercial labs, and they might provide training or technical assistance on any number of topics. And for these purposes, they have standing communication mechanisms. They may have newsletters, they may have listservs, they may have regular quarterly meetings with laboratory directors for particular purposes, but they certainly probably have contact information. Public health laboratories also participate in the National Laboratory Response Network for Biological Threats and serve as reference laboratories. Part of the responsibility of public health laboratories in this role is to maintain up-to-date information about clinical laboratories that serve as sentinel laboratories in their jurisdictions. And that includes, and it's very specifically defined, the contact information about laboratory directors, their names, their titles, their email addresses, and their phone numbers. So work with your public health laboratory to develop your assessment. They can also help you use the right kind of language that's going to make sense to your laboratory targets in your assessment. They can help you focus on the appropriate labs, and they can certainly connect you with the right people in those labs. You might also consider jointly sponsoring your assessment activities. For example, you might be able to get your state or local public health laboratory director to co-sign your invitation to participate in a survey or to participate in a meeting. They might announce it at a regular meeting or opportunity that they have. This is going to serve also to give your survey efforts or your assessment efforts some credibility that you might not have without that partnership, and it can also help to stimulate response. Disease surveillance and informatics programs routinely communicate with laboratories. So these programs can help you to identify potential laboratories that are a target of your assessment. They might also be able to help you with connections. Even if their contact isn't the right person to complete your survey or to participate in an interview, they can more than likely connect you with somebody in their laboratory that is the right person. Another option is licensing boards or agencies. Laboratories have to be licensed. In many states, the licensing entity or agency for laboratories is within the health department. And a licensing board might be able to provide you with a list of all of the clinical laboratories in your jurisdiction, along with contact information. They might also be willing to assist with communication, either through sending out an email blast or helping you to swidden down the list of laboratories that might make sense for you. Center for Medicare and Medicaid Services, CMS, has online a listing of all CLIA certified laboratories, and it's organized by jurisdiction. You can get the name, the mailing address, and the type of certificate, whether it's a high complexity, a low complexity, a moderate or low complexity laboratory. So those are 4 sources of information. You might use one, you might use all 4 of them to different degrees. It depends upon what you have access to in your jurisdiction, but these are all sources that we encourage you to consider. So what methods can you use for assessing laboratories? Disease surveillance data is one I think that is important to think about. All health departments have disease surveillance data. At a minimum, you should be able to use that data to identify which labs are performing viral hepatitis testing and the volume of positive results. This can at least help you to identify highest volume reporting laboratories. And depending upon whether you have the capacity or the authorization to receive negative results in your jurisdiction, it may also help you to identify overall screening volume and reflex testing. You might also consider a survey. I know there has been a number of questions that have come through as we were developing the toolkit about how to go about surveys. Survey can be done in place of or in addition to analysis of disease surveillance or potentially other sources of data. A survey can help you to gather granular data that's going to help you to contextualize surveillance data and to more deeply and precisely understand laboratory practices. It can also be an opportunity for you to identify gaps and opportunities for improvement in laboratory capacity and practices. There's a variety of different ways you can do surveys. There's a bunch of online tools that you may have access to. Some of these are free or low cost. RedCap is one that a number of health departments are using. SurveyMonkey, I think most of us are probably familiar with. Many of us also use Microsoft products, and Microsoft Forms is another one that can be used. There's nothing wrong with paper or Adobe fillable forms. Those might be preferable. Sometimes you might also consider collecting data through interviews, phone calls, or video chats with laboratory staff. You might also consider there's benefits of using a combination of these as well. With respect to surveys, I'll mention again that collaboration with your public health lab, with your STD or your HIV programs or other health department programs is probably something worth considering. You may have mutual shared interests. It might be that the HIV program or the HIV surveillance unit within your health department wants to learn similar sorts of things about laboratory capacity. And in that sense, collaboration can be used to help connect with people in laboratories. You can share your lists of contacts. You can also share the burden of actually fielding a survey and/or of analyzing data. The nature of surveys, though, is such that whether you're surveying laboratories or community-based organizations or NASTAD members, is that you need to plan for some follow-up to optimize your survey response. And so you will need to, as you're planning your survey, plan opportunities to prompt response. I get surveys, we all get surveys, and a nudge after a few days or a few days before it's due is important and useful. And depending upon your overall response rate and your bandwidth, I would recommend that you also consider about more tailored outreach and response. For example, you may have certain high volume laboratories that you want to get a response from, you're just not getting a response. It may mean that you have to do some personal outreach, to make some phone calls, to call on someone else in that laboratory or in the facility in which the laboratory is based to nudge a response. You should also focus your assessment efforts or your survey efforts to align with your capacity as a health department. It may not be feasible for you to survey all clinical laboratories in your jurisdiction. You might, instead, it might make more sense for you to focus only on a subset of the highest volume reporting laboratories. Another data source that or source for information that you might want to consider is administrative claims data. Laboratories bill health insurance for testing services, and analysis of data on the claims that they submit to health insurers can provide information about the volume of screening tests, the extent to which reflex testing is being performed, the interval between screening and RNA testing. This may also be helpful. This may also be a data source that's worth considering for your health systems assessment. Health departments may be able to access Medicaid data because Medicaid is part of the health department, certainly a sister agency to the health department, or they could, it's possible to be able to submit an analytic query to the Medicaid program for a report out of their data warehouse. Some states have all payers claims data sets, which include Medicaid and data from commercial payers. Same sort of process might be entailed in that, to submit an analytic query and to be able to obtain data on laboratories. and testing practices. There are certainly other sorts of methods that could be considered. These from our experience and observations were probably the most common that are or could be used in conjunction with assessment of laboratories. And hopefully during our discussion, we'll learn a little bit more about what some jurisdictions might be using, which are other than the three data sources that I have mentioned here. All right, so you've done your assessment. What do you do with the findings? At minimum, it is really important and courteous, honestly, to share the findings of your assessment with the laboratories that contributed. This is a best practice. It's also a strategy for engaging laboratories and fostering buy-in for any actions that you might want them to take in terms of changing practice. You also want to share the findings with other stakeholders. That might include clinical providers, administrators of hospitals and health systems, certainly your advisory groups that are involved in elimination planning, all for the purposes of raising awareness and fostering an understanding of the impact of current practice on achieving our public health goals and objectives, and to stimulate development of an identification of strategies to address the findings about laboratory practices. Certainly, we want to think about how the findings can be used in education, training, technical assistance, capacity building to stimulate practice, policy and practice change. And I want to acknowledge at this point that health departments have expressed a fair amount of concern about their capacity for undertaking training and education, technical assistance for laboratories. And while the specifics of how to plan and implement technical assistance education for laboratories is beyond the scope of the tool that we're talking about today, we may talk about it at a future opportunity, but I want to encourage you to consider that health departments shouldn't and really can't possibly undertake all of the education, training, and technical assistance on their own. So part of the value of sharing findings of your assessment broadly with stakeholders, certainly with laboratories, is to create awareness of the need and to develop partnerships that can help to provide the capacity around education, training, and technical assistance. All right, this is the fun part of the toolkit. Throughout the toolkit, we have provided links to a number of resources that can help you in developing your assessment approach and tools. But this particular component of the toolkit is probably going to be the most useful for you. And that is a question bank. We have culled through the surveys and assessment tools that have some jurisdictions have already implemented and have organized them in the context of these different sort of buckets of areas of inquiry. So there is an extensive question bank, and you can feel free to pull from that as you develop your own assessment approaches, which may include surveys, interviews, or other. Conducting an assessment of laboratories in your jurisdiction can feel overwhelming, and honestly, it isn't a small task. And with respect to the toolkit, I want to leave you with a few thoughts. Be very intentional in designing your approach and methods. What do you really want to know? What do you need to know, and why? So be very thoughtful about what you're trying to learn from this assessment. Collaboration is really, I think, something that you should consider strongly. You shouldn't try to undertake this on your own. A viral hepatitis program or the surveillance staff or program staff shouldn't try to do this on your own. Your tools and your approach are going to be better informed. You're going to have better credibility, and your product utility is going to be greater if you collaborate with others who have shared or similar interests. And you can also share the burden of doing all of this if you can spread it around across a number of different staffs or organizational units within your health department. I also want to encourage you to think about feasibility. Only do what it is that you can do. If you can't do a statewide survey of clinical laboratories because you just don't have the resources and the bandwidth, focus your efforts on a smaller group. Use surveillance data to help you focus. Learn as much as you can from the data sources that you already have available before you take on an additional means of collecting primary data. And then finally, I want to encourage you to really commit to sharing findings back with the laboratories. It will be very much appreciated. It's also an opportunity to engage them again in a conversation around laboratory practices, particularly implementing screening and reflex testing for hepatitis C and for other infections, if that's relevant to your jurisdiction. And it helps to create awareness of the problem that, and I use that sort of in quotes, the problem that you'd like to solve, whether it's increasing the uptake of screening, implementing an integrated approach to viral hepatitis and HIV testing, whatever it is, it gives you an opportunity to get that in front of folks and to continue to have a conversation with them. All right, quick breath. I'm going to shift gears just a little bit, and I don't think I'm getting the hook quite yet, but I'm getting close. So I'm going to go through this next bit pretty quickly. I want to spend just a couple of minutes telling you how Massachusetts particularly went about our laboratory assessment. And I'm just going to really focus on our process for developing and executing the assessment. And I'm not going to talk to you about the findings in detail, but I'm going to give you a little bit of a preview, and I'm happy to chat later about those. So our assessment, we took a really highly collaborative approach. 4 divisions within our Bureau of Infectious Disease and Laboratory Sciences were involved in developing the approach to it, the tools to it, implementing it, and analyzing it. Our Division of Epidemiology, where our viral hepatitis surveillance and epidemiology program sits, was involved. Our Division of Surveillance, Analytics, and Informatics, which manages our integrated disease reporting and case management system. Maven is what we use. They're responsible for managing that. They were involved. My office, the Office of Healthcare Planning, which is responsible for policy development and evaluation, capacity building, training, and technical assistance, among other things, was involved. And importantly, our state public health laboratory had a key role in our assessment activities. Our primary objective in doing the survey was really to collect the data and do the analysis to help inform education, training, and technical assistance, focused on laboratories and on the health systems in which those laboratories operate. A secondary objective for us was to verify our understanding of reporting labs. Our focus was exclusively on hepatitis C, because that is consistent with epidemiologic impact in Massachusetts. And our assessment looked at laboratory capacity and practices relevant to screening implementation and expansion and implementation of hepatitis C reflex testing. We had sort of a 2-step assessment process. The first used our existent surveillance data. We pulled laboratory data from a 12-month period, including facility information, test results for hepatitis C, and the date of collection associated with those samples and tests. We looked at when antibody test results and RNA test results came through, what the date of sample collection was on those. If the day of collection for both the antibody results are associated with the antibody test and the RNA test were the same, we called it a reflex test. If they were not, it was not a reflex test. So that the first group of 3 tests on the first 3 lines you see on this slide on June 19th, 18th and 19th of 2021, that big X means we did not consider that a reflex test. The sample in the second set occurring on June 18th of 2021, the 2 lines at the bottom of the screen where the green check mark is, we did consider that testing with reflex because the data collection occurred on the same day. We could have stopped here, but we wanted to learn more about the specific practices in individual labs and about their challenges and facilitators associated with screening and reflex testing. Again, our collaboration was really key. We leveraged a previous survey effort of laboratories that we did in 2019, I think it was. We did across a number of infections, and it was really it was fairly surveillance focused in terms of learning, what platforms, what tests were being done, how test results were interpreted. So we had a process in place. Is my point. We were leveraging some previous work that we had done. State Public Health Laboratory provided us with really useful subject matter expertise on the tool. They wanted to make sure we got the language right so that we were approaching laboratories with some degree of credibility. They also wanted us to be very circumspect and very parsimonious in the kinds of information and the length of the survey. And our State Public Health Laboratory director co-signed the invitation with me to participate in the survey, and they provided us with contacts and helped us make contact with laboratory directors. We did a self-administered online survey. We focused on our Sentinel clinical labs and reached out through both the directors and through the micro directors of those laboratories. There are 57 of those laboratories in Massachusetts overall. The domains that we focused on here are current testing practices, orders the test performed, the referral relationships, and the volume and yield of antibody and RNA testing. We got a tremendous response rate. We got 81% of laboratories completed our request for the survey. It did take a little bit of follow-up over roughly a 6-week period. There were, some of the strategies that I mentioned to you earlier in terms of, the personal touch, calling or reaching out through people that to get those contacts. But overall, we consider this pretty successful. Just a couple of things on the findings. When we went into this assessment process, we had some assumptions about laboratory capacity and practices. And we learned through our assessment process that those assumptions were mostly not correct. What we learned in a nutshell is there is huge variability across laboratories regarding screening and reflex practices. We assumed, for example, that really big academic hospital labs were going to be doing a lot of screening and they'd already implemented reflex testing, and that just wasn't the case. Some of our largest volume hospitals and health systems actually were doing a relatively low volume of screening and really weren't doing much reflex testing. And on the flip side, some smaller community hospital laboratories were doing relatively high volume of screening and had implemented reflex testing. So this was important for us to really understand the current status and to help us think about how we're going to work with health systems in making some practices both through the clinical practice but also into their laboratory practice. Laboratories also told us that there are a couple of key issues that they would struggle with relative to implementing reflex testing. One is that changing workflows, particularly when there are multiple laboratories involved in executing a sequence of tests, is going to be tricky for them and challenging. And so we need to be attentive to that. And two, that provider, they feel there was a strong sense that providers are getting provider buy-in, clinical ordering provider buy-in to changing any laboratory ordering or reflex testing implementation is going to be a challenge for them. Almost done. Just want to highlight a couple of key lessons. Our two-step approach to using surveillance data as a starting point and following that up with a survey really helped us understand how to focus our survey efforts. And also, but the survey then provided us with important contextual information to interpret the data that we get through surveillance, and also to help point us in the right direction in terms of any education, training, or technical assistance. Collaboration across the four divisions that I mentioned, and particularly with the State Public Health Laboratory, was really critical to our success, our overall success with our assessment efforts. And then our next steps is we are currently in the process on following up with the laboratories to get them the findings and to think about how we engage with them going forward. And simultaneously engaging with other stakeholders, including clinical partners and our advisory groups to think about how to use the findings from this assessment and related activities to begin to develop some education training and technical assistance. And that is all I have today on this. I think now I am turning things over to Danica.
Correct.
Yeah, hi everyone, and Lisa, thank you so much for that. That was really comprehensive, and this toolkit is, I think, going to be a really useful tool. I've already learned so much, both from your presentation, but also reviewing the toolkit. I think that there's a lot of things that we can all keep in mind when either approaching whatever step of this process as we have. And so with that in mind, just for everyone else, we, keeping in mind the cooperative agreement requirements, wanted to be thinking about approaching you all to discuss creating a toolkit or some other tool to support the health system assessment as well. And so with that conversation, we have a few poll questions that we just want to get out there for everyone. So just to start off, could everyone please answer, have you started the health system assessment required for the 2103 component 2 project?
I launched it, right?
You launched it.
All right.
I know this is shaking out the cobwebs for everybody in the late afternoon. So if you could share your thoughts and your feedback, we only have a few of these questions just to kind of get a sense of where everybody's at. Mine says that one person has participated so far.
Correct. Great.
Okay, let's please just put a few answers in. I promise the actions will be limited. People are starting to answer. Thank you, everyone.
Thank you.
Got a variety of responses. Maybe we can give it another 10 seconds.
Was I supposed to count the 10 seconds?
Oh, yeah, it doesn't matter.
Okay, sorry.
We can cut it now. Thanks,
Yeah?
everyone. I know you're still responding. Yeah, let's move on to the second question. It looks like we have a variety of progress amongst jurisdictions. All right. All right. Am I supposed to click end the poll? I'm sorry, Isabel.
No, I'll click it.
Okay.
Sorry. I
No,
also
it's okay.
see the response rate going up. All right, let's see here. There we go. Can you see the results?
All right, so it looks like there's a variety of progress. A few people have, or jurisdictions have finished their assessment. So really excited to hear from those sites, and it looks like a good portion of folks are in process. So it'll be exciting to see where people are at. And then there's a lot of we're all doing a lot, and it looks like some people might really benefit from this conversation and thinking about where to even begin. And then some drama, not some drama, with not knowing, with having not started yet. And for those who are concerned about what we're even talking about, hopefully it's not even your responsibility. And for the rest, we'll clarify a little bit in this conversation. Okay. Do we want to? Oh, I'm sorry. I didn't even see all the other things. I've never done a poll before, guys. I'm sorry. Okay. So when thinking about some of the biggest challenges to completing the assessment, it looks like there's some feedback across the board, thinking about how to identify systems, really how to get responses from health systems. I'm sure this is something that, what Liisa was referring to, just trying to get even response. 81% was really impressive, Liisa. So hopefully we can get that for health systems too. And then just figuring out who does what when, making sure this is useful. So this is all really, really helpful. So thank you guys. And it looks like some people are, about a third are going to be focusing only on Hep C, and then the rest are hopefully going to be focusing on both B and C. So really exciting. And I have HBC here, so you guys can see where my brain has been at, HBV. And then in terms of what you think, feedback and guidance and some maybe discussion around a toolkit would be at, it looks like talking about barriers would be really helpful, as well as any examples to give feedback after the assessments to sites, and then survey question examples. I think as with the labs is really helpful. So this is really, really helpful. Isabel, this is all going to be shared, or we can save that, right? Somehow? Yes. Okay, cool. All right, great. So if you guys have any other thoughts or feedback, please, throughout this discussion or after, don't hesitate to put them in the chat. But for now, I think we want to open up and have a discussion both about the toolkit that Liisa discussed for the labs, and then also thinking about the health systems, what we can be thinking about in terms of approach and content that will be helpful to everybody. So with that, Isabel, I'll stop my jabbering.
That is not jabbering. That was very informative poll that you led. Thank you so much, Danica. How about we start then with the questions that I think I saw a question come through from, yes, I think this question is for you, Liisa, from Rachel. We're thinking of making same assumption, if AB RNA, same date, assume reflex. Wondering if anyone has validated this assumption. Okay, so it's for everyone.
This is Tony in Massachusetts. I can chime in a little bit about the methodology there. So we didn't do any formal validation of that assumption about if it was done on the same date, say an antibody and an RNA actually being a reflex. We didn't validate by way of medical records or anything like that. But where we could, we did make use of specimen ID number or the accession number to ensure that what we were calling a reflex actually was the same blood draw. So that was one component that we used in it.
I will also say, and Tony, you might still be in the process of doing a little bit of crosswalk. The very superficial review I did of crosswalking the survey results against the analysis of surveillance data is when laboratories said that they were doing reflex testing, that generally aligned with where we saw in all or certain circumstances, generally aligned with where I think we assumed, based on the methodology that Tony and I have described, that reflex testing was a happen. Again, not an utterly scientific evaluation of that, but there was I think general concordance.
Danica, do you want to chime in?
I don't have anything in particular.
Okay. And then folks, you can also raise your hand throughout. So I'm going to, let's talk about then, so it's going to be kind of a two-part question. First, for Liisa and Danica, can you tell us where your jurisdiction is at in terms of both assessments, and then what your specific roles are? And then if you were to implement these assessments from a jurisdiction that is just starting out, has limited bandwidth and resources, what would you recommend you start with and focus on?
We are in the process of developing our health systems assessment approach, and the thing that I think we recognized after the laboratory assessment is just how complex health systems are. There's been a lot of mergers and acquisitions, if you will, among hospitals in Massachusetts, and laboratories go along with that. And I think we learned a lot about how those multiple laboratories within a health system and multiple hospitals associated with sort of the mothership as part of that health system make this really complicated. At least in our instance, I assume that there's that's similar in other jurisdictions where you have one academic teaching hospital, and then there are a dozen or more other community or other hospitals that are affiliated with that, and there may be a laboratory in every one of those hospitals. So it's a lot, and I don't foresee us going to every health system in Massachusetts. We are going to be, I think, very circumspect about trying to dig in a smaller number of systems to try, because we don't have the bandwidth to do all of those, but also I think it's a lot to try to take on and then plan system level changes, supporting system level changes. So, my overarching recommendation is to think about this incrementally and think about where you can get the most juice for the squeeze, either because it's a big laboratory or set of laboratories with high volume, or same with health systems, or because you have a foot in the door for some other reason that you can actually get people to talk with you and you work with you, meaning the juice is going to be worth the squeeze because somebody is going to take your meeting and be open to working with you and open to making changes. So just be very thoughtful and circumspect about your approach, and absolutely don't try to do it all. It's just not possible.
Yeah, I mean, Liisa said a lot of what I would say is, bite off what you think you can chew. I mean, I know in Philadelphia, the top health systems have 5 hospitals each, and each of those health systems have primary care networks as well, and they have specialty, they have hepatology, transplant units, they have delivery hospitals associated with them, labor and delivery. So, thinking of for us, we're in process right now as well, and I think that we're in the, trying to really think of those the biggest impact with the most realistic impact, like Liisa was saying. That's where we're at. And so for us, the CDC and the cooperative agreement defines health systems, and that's a very inclusive definition. I think for us, we struggle with, when thinking about a health system that really encompasses a lot of different care points. And so how to think about assessing what testing recommendations are happening in those very different and very broad settings across very different and broad geographical areas as well. And so those, I would just encourage, especially newer sites, to think about what resources you do have and to think about what pieces you can do. I think we all need to be mindful of the resources associated with this project as well, and that the impact could potentially be big here if you can really build those relationships and identify some areas for improvement and change your big health system practices to move the needle towards elimination. But I think you need to just be mindful of what resources you have and other activities you have going on. So long answer. One question or one request I would make is for the health or for the jurisdictions that indicated that they have completed their health system assessments. If you wouldn't mind either direct messaging me or sharing in the chat with everyone else, or you can email me or Isabel, that would be really helpful. It'd be great to hear about the successful approaches that folks have had, or the not successful approaches, because I think we're all trying to not reinvent the wheel here. And that would be the other maybe piece of advice for all of this is, recommendations exist. CDC has some materials along those lines and other professional organizations. And so the more we can utilize existing materials or existing surveys and assessments, that's what we're trying to support you guys all with as well, to provide those resources.
So on the same tangent, can you speak? So this is actually for Liisa, Danica, and the audience. We're hoping that attendees can also provide input through the chat or raise hand function, but can you speak more to the partners that you've leaned on for your assessments?
As I mentioned in my remarks, this, in doing our laboratory assessment, we worked across divisions within the Bureau of Infectious Disease and Lab Sciences, and that included, I think most importantly for the laboratory assessment component, our state public health laboratory. We would not have been as successful if we didn't have a partnership, in particular with the public health laboratory. For the health systems assessment, I have to imagine that we are going to continue to lean on multiple divisions.
Do we lose Liisa?
We lost Liisa.
Okay, all right.
They may be helpful. So working in other organizational units within the public health department.
Thank you. Your audio went out, but you summarized what you said in the last few words. So thank you.
Yeah, I mean, I think for us collaborating, I mean, surveillance is really important. Rachel in California is saying they partnered with Primary Care Association to reach out to the highest volume FQHCs. I think that's a really good strategy, or other community health center professional organizations. We've also, as a part of our component 2 elimination planning work, done a lot of organization for technical advisory committees for the elimination plan. And so we have quite a few champions on that from major systems as well. And so hoping to leverage those partnerships and those champions to help facilitate the assessments internally as well. And so wherever you have built those partnerships for other pieces of this project or the surveillance or the prevention side of things, really trying to build upon those relationships, I think will be fruitful.
All right, in terms of general recommendations, or you can answer either or question, but one is any surprises that you've encountered from whether it be implementing or preliminary results of your assessments, and if you can speak to kind of preemptively, what are some general recommendations that you're providing for both the systems and the providers? And this is for Liisa and Danica and the audience.
Go ahead, Liisa. We haven't completed ours yet, so I don't really have any findings quite yet.
Yeah, I mean, I think that a couple of the surprises that we didn't anticipate, I talked about in my remarks, and really it comes down to just, the assumptions that we had about hospitals and laboratories that we thought would be doing something other than they would. So learning about that, I think was useful, and it makes the health systems assessment and then certainly any technical assistance a little bit trickier. I think the thing that it might be really helpful to hear about, though, is I spent a lot of time actually talking to people on the phone to prompt response, and I was really pleasantly surprised that laboratory directors and staff really wanted to learn more about what public health is up to and interested in, and why we thought that we wanted them to do something different. They're actually really for engagement with public health about, in this context, changing laboratory practices. But they also wanted us to sort of be a bridge with clinical providers around developing that buy-in for any sort of practice change. So that was a really pleasant surprise. And I think that if we hadn't actually, had sort of that human interface, I might not have learned that. But I think it's really useful. Don't underestimate that, the subject of your assessment is really eager to make some changes and to do groovy new things.
All right, I don't see any raised hands or comments in response to that, but I would be interested in hearing more about maybe future plans, or where you can see there is opportunity to leverage the expertise of people with lived experience, or coalitions, or general communities you serve for these assessments.
Yeah, I mean, I think that rounding out the communication cycle from, including the public health labs, including providers, including public health, but also including the communities most impacted, is going to be really important. And especially when talking about, people who use drugs or who exchange sex for money or drugs. These are groups that experience stigma in many healthcare settings, and so the more that we can be trying to remove that stigma from systems as well as from providers, and including them in the conversations, or including their experiences in narratives and feedback, I think is going to be really important. And so because that's not often something that is a part of the interface or the consideration for many providers or many systems. And so I think if we can do that and humanize the experiences of the people who are most impacted by this work, we can hopefully move the needle a lot faster.
Yeah, I absolutely agree with you. And one of the things that we are in the process of beginning to develop is some provider facing materials and opportunities. We don't know exactly what they look like yet, but is exactly to have that consumer experience presented and available in this instance for clinical providers, because it is, I think, missing currently from training, education, awareness building, and something that for all of the important reasons that Danica stated, urgently needed.
Perfect. I think that's going to be the perfect way to end our conversation. So with that, thank you so much, Liisa and Danica, for your contributions and your expertise, our conversation we had today. And yes, this recording will be available probably within 48 hours on our YouTube channel, NASTADs, and then on our microsite. So thank you. And our resource will also release via an email with this recording. Any questions at hepatitis@nastad.org. So thank you.